This is Ketamine. Most of you know who I am. For those of you who don't, my name is Tony McCormick. I am I'm the flight paramedic and the clinical supervisor for LifeNet. I'm also an ER nurse at Truman Hospital Hill, and I've been here at AMR for
Liberty and AMR.
Yeah, I'm not Liberty anymore. Just Truman as a nurse, and then been here part-time for a little over 8 years. So this is my presentation on ketamine. A lot of the material in this presentation, as a disclosure, is not my material per se, but it's a combination of research and studies that I put together, and it's based on my own experience giving ketamine. I am not an educator. I'm an operations person, so I don't talk on something unless I'm intimately familiar with it or interested, have first-hand knowledge of how it works and have a genuine interest in it. So ketamine is something that we give a lot in the air. I give it 2 or 3 times a week. I just gave somebody yesterday 600 milligrams of it. So we give it almost every day on shift. We use it. Same in the ER. We use it a lot for our conscious sedation in the ER. So ketamine is reemerging in the acute care environment and in the ER side of things, and it's very quickly becoming the sedation drug of choice in the transport industry. Air is starting to use it almost all across the board, and now the ground units are finding it's very useful for those services that are doing vent transports and for pain. But we'll get more into that here in just a second. The disclosures, like I said, content of this presentation is just a combination of what I know firsthand using it and from other people's research and studies. I have resources are available if you need them, and I don't receive any financial benefit from ketamine or Ketalar, which is the brand name for ketamine. That's the vial that you're going to have in your NARC box that's going to be ordered from McKesson. I actually brought some of that. Last week I didn't have any vials, but now you've got a vial in front of you, so if you can handle it, see it. That is the exact vial that you'll have. Right now, there's just cranberry juice, so I'm sorry to disappoint. So just walk off with it. It's not going to go away. It's 500 milligrams in a 5 ml vial, so it's very highly concentrated, which is great for your patients who require sedation, and it's great for those patients who are going to give it IM to for behavioral, and we'll get into that further. You'll see I put some, I usually use a 3 cc syringe when I give it. If you're going to give it for pain management, the dosing is much lower, so you may find it beneficial to use a 1 cc syringe that we never use. So we are going to I'm going to have Jason order some Luroloc 1 cc syringes, because trying to push a med and hold it in the Luroloc, you end up spraying it all over yourself. So we're going to get some Luroloc syringes for 1 cc's if you choose to use the 1 cc. But as when we get into the dosing, you'll understand why a 1 cc is beneficial. So what is ketamine? Ketamine is categorized as a dissociative anesthetic. At lower doses, it is a very, very, very powerful pain medication. It doesn't cause any changes in your cognitive ability, doesn't change anything, or doesn't have any effect on the brain, other than pain perception. Higher doses is where you get the dissociative effect. And we'll get further into that, but essentially the brain is disconnected from any external stimulus, so the patient is not able to interact with you. The patient, you could cut their arm off and they care less, which makes it a fantastic drug for the sedation patients.
You can't really do that. I should. Someone might need it.
You might need to give that to your partner there from time to time.
Oh no, I'm always.
It is a indirect sympathomimetic. So some direct sympathomimetics that we have. One that we have, can anybody, a sympathomimetic that we have in the ambulance that acts on the sympathetic nervous system? Epi. We have Epi. That's a sympathomimetic. It's one of the pure sympathomimetics that we have. And then albuterol. So with ketamine being in that category, it has some beta-1 effects on the heart, but very, very, very profound beta-2 effects. So you get the bronchodilation with ketamine. This presentation is not just for AMR, it's one that I give other places too. So those places that use RSI, ketamine is very, very effective in patients that you're going to induce sedation on before you give the paralytic, unlike your status asthmaticus patients, the ones that are about to die or we need to do something. So those places that have RSI might choose RSI. There have been case reviews done where a crew has given a sedation dose of ketamine prior to the paralytic, and it has stopped the brain from interacting with the rest of the body, other than your respiratory cardiopulmonary tone. We'll talk about that later. But it's isolated the brain. It's eliminated that air hunger. The patient's able to relax. They're not anxious anymore, they're not starving of oxygen, and because of the beta-2 effects, it's opened up their airway, it's opened up their alveoli, it's opened up their bronchioles. And when there has been case studies how the crew has given, they haven't even gotten to the paralytic, and the patient it's reversed their status schematics and saved them from having negative tubes. So it's a very, very good drug for patients that are your severe respiratory patients, if you have an indication to give it for RSI. We talked about it's a strong analgesic at low doses. At high doses, it's a very potent sedative. There is a middle dosing range, and we'll talk about that further. There's a graph, and I'll show you. It'll make more sense. But that being said, ketamine is weight-based, and that's why it's weight-based. It's very good that you either ask the patient their weight, or you're very good at estimating, because you'll need to know their weight in kilograms to dose it. I can't just throw out an arbitrary, everybody gets 20 ketamine for a femur fracture. It's very weight dependent, because if you're giving it it's not as big of an issue for the sedation dose, because if you give it a little bit more, it's just going to last a little longer. It's not going to increase the sedation. There's just a peak. But it's interesting when we come to the analgesic dose, you want to give the right dose because you don't want to get up, and there's a recreational use range. And I'll show you the graph. It'll all make sense here in a minute. That's the range that people that use it as a party drug, people that snort it, smoke it, stuff like that, they're getting into that recreational range where they're using it because they like that partial dissociation. They like feeling numb or feeling detached from reality, but they're still able to walk and talk in most cases. There is no clinical significance for us to dose in that range. If you do give a little bit more for like a hip fracture or whatever, and you get up in there, it's not an emergency. It's not a big deal. The patients might just feel like they're having an out-of-body experience. Kids might freak the hell out. Children's Mercy used to have an issue with ketamine. I think they've kind of come around and they've understood the risk versus benefit. There's very little risk and very good benefit. But just understanding that there's the pain range, the middle range that we don't really need to dose in, and the high range. Either give a little bit or we're going to give a whole lot. Come on down. So ketamine, it's fantastic for pain management with those patients that have a history of opioid use or dependence. So you're a heroin addict that gets hit by a car and has a crushed pelvis. You're going to start an IV on her. Eventually you're going to give her some pain medicine. That's what we do, we treat pain. Is 100 mics of fentanyl going to do anything for somebody that's been using heroin for years? Absolutely not. So in this case, I'd still give the fentanyl. In fact, the protocol is written, you will give 50 to 100 of fentanyl, and then you can consider ketamine if pain is not responsive to the fentanyl. So you can give fentanyl or morphine, whichever you choose to give her pain, and then ketamine after your first dose if those opiates are not effective. So your lady heroin addict gets hit by a car, crushed pelvis, you give 100 of fentanyl, doesn't work. Ketamine would be this would be a perfect scenario that you would give ketamine in, because that 100 of fentanyl is not going to do anything. Grandma gets hit by a car, or it's Christmas and she gets ran over by a reindeer, whatever.
We had that happen one year.
She's had a fentanyl patch for 10 years. Is your 100 of fentanyl going to do anything if she's got a high tolerance? Probably not. Fantastic drug for that case. So anybody with a history of opioid use or dependence, I've had patients tell me in the ER that have had legitimate injuries. They're not just seeking, and they've said, hey, I'm in pain, but I don't want anything for it. I don't want any opiates. Don't give me any morphine. I don't want Dilaudid, none of that, because I've used for years street drugs, and I'm clean now. But they're obviously in distress, and they're tachycardic, they're anxious. So ketamine's a good go-to for that. So even though the protocol is written, fentanyl and morphine, and then give ketamine if you don't have a response to that, and I've discussed this with Mike, and he's all about it, and he gets it, that there may be situations that you need to treat the patient depending on what the patient needs. There may be situations where ketamine will be your go-to drug instead of an opiate. In the case of, I don't want fentanyl or morphine, but I need something for pain. You can tell them, hey, this is not an opiate, this is not something that you're going to get. It has very low addictive properties. That's why it's a class 3, not a class 2 sodium substance. You keep calling it cake. It's going to make you feel weird, but it'll stop the pain, and it's not going to get you back into that habit of using drugs. It's not going to give you that high that now you're going to go chase once you get out of the ER. But it's going to fix the pain. It is safe in all patient populations, and there was some articles published a while back that it was non-conclusive in kids. It's not that it wasn't safe in kids; they just didn't have the data. Well, since ketamine's been around, It was synthesized in the early 1960s from PCP. They were using PCP during the war times, especially in field ORs, for their sedation. And they wanted something that didn't have the terrible side effects that PCP has. So they synthesized ketamine from PCP. Safe in all patients, just a little side note, a little background on ketamine. So in kids, so as they've progressed, they've pulled over, there's been over 1 million patients that have been documented that have received ketamine in the hospital environment. And there's no cases linked to patients being harmed as a direct result of receiving ketamine. So I want you guys to feel very safe getting ketamine. You're not going to harm your patients. There's nothing out there that shows that patients have had any negative effect directly related to ketamine. Patients have died that have gotten ketamine, but they've not been able to link it because of ketamine. Right. For fentanyl and Versed, we can kill patients. We can tank their pressure with Versed. We can knock out their respiratory drive. So if you feel safe giving those drugs, there's no reason why you should feel uncomfortable getting ketamine. I would venture to say it's one of the safest drugs that you're going to have in our drug box. It's the preferred sedative of choice in RSI in pediatrics to 9 months old. This kind of blew that whole, well, we don't know about kids, that kind of blew it out of the water when they came up with those services that do RSI know that etomidate is contraindicated in people with adrenal gland insufficiency. And kids that are 9 months old and younger, they don't have fully developed adrenal glands. So your go-to drug if you do RSI in a kid is ketamine. And that's our go-to. We have a couple options, ketamine or etomidate. Most of us that do RSI, if they have 10 year olds, you get into everybody. Because more across the board, ketamine is safer for patients than etomidate. Unlike opioids and benzos, it will not cause hypotension or respiratory depression. Remember, it's an indirect sympathomimetic, so it's going to act on the sympathetic nervous system. So if you get a response at all, it's going to be a little bit of increase in their heart rate, a little bit of increase in their blood pressure. So those vent transfers that we've all taken, or most of us have, and we don't have a sedation protocol, so I've been sent with order for PRN Versed, or PRN fentanyl. Well, fentanyl for one is not for sedation, it's for pain management. And Versed is terrible for long-term use because you'll tank their pressure. You give them a couple rounds of Versed and fentanyl, and now you wonder why your pressure's in the tank. I've QA'd charts on the flight team where I've looked through on vent transfers, and patient's good, fine, and suddenly the crew is giving fluid boluses and trying to fix the patient because they're hypotensive. And I look back and see what they've done. They've given 3 or 4 rounds of fentanyl and Versed and tanked their pressure on a patient that was otherwise hemodynamically stable, other than being on the ventilator. So my response always is, why didn't you give ketamine? I mean, yes, we give our crews options, but why would you choose something else over ketamine? And a lot of it's just unfamiliarity with it and people not understanding how ketamine works. So like we said, may see a slight increase in blood pressure and heart rate if you're going to see any changes at all. And that's going to be in the higher doses. In the pain dosing, it won't really affect the heart and the lungs. So at the higher doses, at the sedation doses, it isolates the patient's brain from the rest of the body while maintaining cardiorespiratory tone. So what don't you have to worry about? You don't have to worry about it causing respiratory depression. The heart rate is they're going to maintain that heart rate. They're not going to lose their gag. So if you may see a little bit of hypersalivation with it. Some studies say I give it 2 or 3 times a week for the past almost 4 years, and I've never seen hypersalivation. But if they do have it, their gag is still intact, so they're not going to aspirate, they're not going to choke. Their brain is just going to be checked out, and they're not going to be able to interact with you at the higher sedation doses. Typically for us here at AMR, those patients are going to be on the vent, unless it's a behavioral patient. But we'll get into the indications for our use here in a minute. Airway reflexes are maintained. So again, the gag is maintained. It's not a paralytic. Somebody asked me once why we're getting a paralytic, and I said, well, ketamine, if you read on it, it's not a paralytic, so they still have their gag intact. Their gag reflexes remains intact. Their breathing. I had I QA'd a chart a few months back, and the crew said, we're never getting ketamine again. We gave it, and the patient became apneic. And I was like, well, unheard of. I mean, that just doesn't happen. So I read the chart. It was a bilateral femur fracture. They gave some fentanyl, 100 fentanyl. They gave one of Dilaudid. And the fentanyl and the Dilaudid, and still the patient was in excruciating pain. So they did the right thing. They went to ketamine. I would have done it a little sooner, but they went to ketamine. They gave him like 30 milligrams of ketamine. And then they charted. Patient immediately went into respiratory depression. Patient was patient ventilated by a VVM for 30 seconds to a minute, and then regained and then started to spontaneously breathe again. And I was like, well, then your patient was an apneic. I said, you charted right here, your patient was breathing 8 times a minute. They're like, well, yes, but before we gave him the ketamine, he was breathing 24 times a minute. We gave the ketamine, there was his respiratory. I was like, no, the ketamine did its thing. The ketamine stopped the pain. The ketamine relaxed the patient. He doesn't need to breathe 24 times a minute now because he's not anxious. So yes, you may see some respiratory decrease. I don't want to say depression. You may see a decrease in the respiratory rate. You may see more shallow breathing because, especially at higher doses, it kind of hits the patient and they get very relaxed. And but that's absolutely normal and that's to be expected, especially in the higher doses. You may not see it as much in the pain management side of things, but if you do, you'll know why, because that's the patient's response. Because their cardiorespiratory tone remains intact, if they're only breathing 8 times a minute, their body needs more. They're going to breathe more. So that's when good BLS care comes in, and just watch your patient. You may want to throw them on a nasal cannula for a couple, on a couple liters, like we do in the ER for conscious sedation. This would be another good case for you to put them on end-tidal CO2 nasal cannula. I mean, if they're breathing, you're worried, you're like, oh, shit, the patient's not breathing, or they look, my partner nudged me once the first time I gave it with her. She's like, tell me he looks dead. Is he all right? I'm like, yeah, we just gave him ketamine. He's staring at the ceiling, like, yeah, he's fine. He's high, for lack of better terms. But that may be a patient where end-tidal CO2 may come in handy, because if you look at your patient, you're like, oh my God, they don't look like they're breathing. They're shallow respirations. This respiratory rate, plummeted from 20 to 8 or 10. But if their SpO2 is maintaining, and their end-tidal is good, and they're perfusing. So you just need to watch your patient and do supportive care as appropriate. There are some patients where if you give a crap ton of opiates and then give them some ketamine, the opiates will finally catch up and they might have some respiratory depression because of the opiates. But it's not seen very often. And again, just supportive care. Yeah, if their SpO2 starts to drop a little, keeps dropping, then they may need some assisted ventilations. But never, I've looked and looked and looked, and the studies are just not out there that have shown patients going into complete apnea after getting ketamine, unless they've had a paralytic. Patients may experience an out-of-body. Patients may feel like they've had an out-of-body experience. Again, pain management level. If we do the right dose and we just give them just enough for the pain management, the lower dosing side of things, they should just feel a relief in pain. Maybe a little bit of numbness. You've had nitrous in the dentist's office. That's kind of what it feels like from what I've read. But the out-of-body experience comes from that middle dosing, that recreational range, and the conscious sedation range that they do in the ER. But actually, a lot of patients enjoy the effects of ketamine and would, in some instances, dislocate their shoulder again just to get ketamine in it. So most patients have no complaints of ketamine. So if you ask somebody about ketamine and they have an issue with it and they haven't completely done their research on it, usually the only thing they can come up with is psychological emergence phenomena. I don't want to give it to a kid, and then they freak out. So again, this is something that if they're, it's seen in less than 15% of the population, and it's completely preventable and treatable. So if you have this issue, it's usually in kids, because adults react pretty well to the recreational range if you accidentally give a little bit too much for pain. But kids freak out if there's anything weird happens. So if the kid feels like he's having an out-of-body experience, or his arm's suddenly numb, or he can't talk out of the left side of his mouth, or he can't hear, because everybody acts a little differently in that middle range, they may have this psychological emergence and scream and look, they'll be they may appear like they're traumatized. The big thing is just knowing that this does exist and knowing what causes it. Usually it's improper dosing, and on the back end of it, when they're coming out of their ketamine high, so to speak, it's treatable. In the ER, we give some Versed, maybe even give them some more ketamine, and just titrate that ketamine down. But just know that you may see it seen in less than 50% of the population, and just understand it's all about proper dosing, and it's all about talking to the patient and letting them know, hey, I'm going to give you this drug, and it's going to probably make you feel a little bit weird, so it doesn't hit them by surprise. The way their mindset going into their ketamine-induced high, again, so to speak, for lack of better terms, will determine how well they emerge out of it. So if you tell the patient, think of something, I'm going to give you a drug for your pain. Think of something that makes you happy. Think of a place that you'd really like to be. And then, if they do get into that recreational range, where they do get a little bit mentally dissociated, suddenly they're at that place that they want to be. They're happy. So the patient is agitated and scared and everything going into their ketamine trip, for lack of better terms, it's going to be a miserable experience for them. It's all about prepping your patient and talking to your patient. And like I said, they can enter a dream state. They can choose their dreams. So just tell them to think of something that makes them feel good, makes them happy, and they'll appreciate the ketamine. So the brain response. This is based on an adult patient, a standard adult patient, we'll say 100 kilos. This just kind of gives you an idea. And there's a graph that better replicates this information. A lower dosing, the 10 to 30, will be gives you an idea of kind of the analgesia dose. For pain management. This is at 30 to 100, that middle ground that we don't really have a reason to be in. And then once you get 100 and over, that's where they're completely dissociated and they're sedated. Giving more than 100 in this case doesn't do anything for the level of sedation. All it does is increase the duration of effect. So there was a case in California where a kid was given over 100 times the prescribed dose, or the ordered dose from the physician for a conscious sedation for like a shoulder dislocation. The nurse gave a gram instead of 10 milligrams, gave 1,000 milligrams. So a 20-minute procedure turned into a 9-hour stay in the hospital because he was completely dissociated for 9 hours. The kid was discharged later and sent home. I mean, with no negative effects. So point being, don't overdose your patient and make sure you know the right dosing. But if you do, what other drug can you give 100 times the dose and not kill them? So if you look at deaths related to ketamine, typically it's people that are using it recreationally or as a party drug, and it's using it crossed with heroin or meth or ecstasy, stuff like that. Straight pharmaceutical ketamine is very safe, especially when used in the clinical setting. In fact, Michael Jackson should have ketamine instead of propofol, and he'd probably still be alive today. Really?
Yeah.
It was bad. His personal physician had made a bad decision. So this is the graphic that is a little bit easier to understand for a standard adult. Remember, don't get stuck on these numbers. This just kind of gives you an idea of the standard adult. This is not my graphic. This belongs to Dr. Ruben Strayer. He did a presentation at the SMAC conference in Chicago a couple of years ago and presented on ketamine. So I borrowed this and put it in my presentation because it shows a very good visual representation of ketamine, the brain continuum. So you want to be in the green for pain management, or if they need to be sedated, or if it's your behavioral patient, you want to be up above this dissociated range. Like I said, once you max out, once you reach the maximum dosing for complete dissociation, giving more doesn't do anything but increase duration, which in some instances you may want. I just flew a patient yesterday. Took her out of a small hospital in Iowa over to Omaha. Respiratory arrest, or respiratory distress, they RSI'd her in the ER. We get there, and she weighs 400 pounds. And somebody brought up a good point. Do you dose ketamine off of ideal body weight, or do you dose it off of actual body weight? Because her ideal body weight, and I estimated her at 400 pounds, but her ideal body weight was around 60 to 70 kilograms. But for a 400-pound patient, 60 to 70 milligrams of ketamine, because it's 1 per kilo, is not going to keep her sedated very long at all. So we dosed her off of her, we gave her 150, and that was on the lower, that was probably on the lower end, we should probably give her 300. But we made, at bedside, I asked RT, I said, you're bagging her, when's the last time when would she have her sedation? And he said, oh, she's had, we gave her sucks. And yeah, I was like, well, okay, lots of paralytic. So she hasn't had any sedation. Got it, perfect. So usually what I do anytime once I make patient contact and I look at the patient and I know they're intubated, I just assume they're either under sedated, they're not sedated, or they're going to need it here pretty quick. So I just just do it and be done with it. It's going to make your job easier once you try to transition them to your cot and then on the trip down in the ambulance. So bring your narcs with you if you get event transport, because I just always assume the patient's not going to be sedated enough, especially like propofol drips. We don't even take those on the helicopter, but that's mainly because it's a glass bottle and we can't have glass in the aircraft. But propofol is not meant for transport. It's fine for ICU, and there's even studies now that are saying that propofol is really they need to get away from it, especially in trauma patients. So they're going to Cerebex. If anybody has any experience around Cerebex, Cerebex is a barbiturate like propofol, but the patient is easily arousable to any sort of light stimulus. So it's great if you're in the dark-lit ICU room and the patient's on the vent and they want them sedated, but then they want to be able to walk in and do quick neurochecks, wake them up, ask them how they're, ask them to open their left eye, right eye, do some neurochecks. Very easily arousable. But that is a terrible, terrible drug for transport because the entire time they're going to be aroused by the vibration, by the movement. So we had a flight, not my base, our sister base had a flight that we did a whole review on with their medical director, where they flew a patient on Cerebex, and their issue was sedation, and we couldn't get this patient sedated enough, and the doctor told us not to give him ketamine for whatever reason. And it's like, well, first of all, that's why we have protocols, and that was a whole other conversation. But Cerebex, if you get a patient with Cerebex, you might as well just DC it and give them a bolus of ketamine and be done with it.
Did you talk to Jason?
And what happens if you DC their propofol? They just lose sedation, right? Well, you have drug now in your protocol for you to give for sedation while they're in your care. They're going to restart that drip anyway at the receiving hospital. They're not going to keep that tubing and that medication that didn't come from the pharmacy. So the biggest issue with it, so some people that have used it have complained that they've given it for sedation and it just didn't work very well. Well, usually because they were unfamiliar with the drug and it was their first time giving it and they didn't really want to give the whole, they were like scared, so they, underdosing. Underdosing is the biggest issue. If you're going to give it, you need to give the whole dose, especially for sedation. So if you do your math and the patient weighs 200 pounds, 90 kilos, you need to be giving at least 90 milligrams. The protocol is going to be written 1 to 2 milligrams per kilo. I would give the 2, not the 1, because again, giving more just makes it last a little bit longer. So underdosing is the biggest issue with the sedation, on the sedation side of it.
So do these patients remember afterwards?
So the ketamine inhibits your brain's ability to form memories. So why historically it's been commonly used as a day break drug? Because it stops your brain's ability to form memories and thoughts. They can form thoughts, but you just won't remember them. No. In short, no. At the higher doses, no. The pain, again, at the analgesic doses, which we're going to talk about right now, it's just going to act as an analgesic and just for pain relief. But no, at the sedative doses, they won't have, it has the amnesic effects like you would get with the benzos.
Okay, thank you.
General indications for use. This going forward will be everything that we can use it for here at AMR. So the first indication we're going to have at AMR is for pain that's unresponsive to opiates / severe trauma. It's not just for trauma though. I've had a 16 millimeter kidney stone, which is, I felt like I was going to die. And the ER, I got Toradol and Dilaudid, and Toradol, fentanyl, and finally got Dilaudid, and it was still hurting. I probably would have appreciated some ketamine, but in any case, if you have anybody that's in acute pain that you're not being able to treat well with your opiates after 1 dose, like your classic kidney stone that's puking and diaphoretic and on the ground and completely debilitated, that's obviously in pain, and you give them some fentanyl and it doesn't work, ketamine will be your go-to for pain that's unresponsive to opiates. When I wrote the protocol with Mike a few weeks ago, we put a range in there. But to make it easy, it's like 0.1 to 0.25. And we might even up it to 0.25 to 0.5, but for all intents and purposes. 0.25 per kilo for pain management. It's the easiest way to remember it. So you get their weight in kilograms. So this is where you need to be very good at either estimating patient weight or asking them how much they weigh, and then converting it to kilograms. And then you give 0.25 per kilo for pain. It's half of a half. Find their weight in kilos, and it's half of a half. So if they weigh 100 kilos, which is 220 pounds, if 100 kilos, that's half of a half, so 25 milligrams of ketamine is what I'll give them. And I've talked to Mike, we'll work on putting in the ambulances some weight conversion charts So you have your weight in kilograms and your weight in pounds, and then the 0.25 per kilo dosing for ketamine. That way, if they tell you I weigh 173 pounds, you can be like, okay, 173, 170 or whatever, you can get in the ballpark. And I always round, if I have a question about it, I always round up. They tell me they weigh 176 pounds, and I'm like, 180, or sometimes 200. Sometimes they haven't been weighing in a couple years. We will be having it for continued sedation. So any patient that you have that's intubated should be properly sedated. The transport industry as a whole, both ground and air, does a bad job of sedating patients. Anybody that has a tube shoved down their throat shouldn't be awake. Anybody that has a tube shoved down their throat should receive good pain management, because patients that get discharged from the ICU after being intubated, the most common complaint is they felt the pain from the tube being in their throat. They gave them propofol, they sedated them, the hospital used propofol, but they didn't do anything for pain, and propofol doesn't do anything for pain. Ketamine will, but we also need to do a good job of pain management. It's kind of a side note there of these vented patients, or anybody that's got a tube. But so anybody that's intubated, whether they're on a vent or not, so your 911 calls that you tube a patient, now you got ROSC, and now they're bucking the tube, they need ketamine. I was working at Liberty in the ER about 6 months ago, and a fire department brought me in a patient that was intubated at a outpatient surgery clinic and didn't go so well, so they decided to call 911. The fire department comes in with this patient who's tubed, and he's grabbing the thing. They're trying to restrain it. I'm like, you need some ketamine, you need ketamine. But they didn't have, they're like, we don't have all we have is Versed, and that's just for, actually, I think it was Ativan. All we have is Ativan, and that's just for seizures. That should never happen here. If that happens here, it's because you didn't give the right medication when the patient needed it. So we should not ever bring a patient to a hospital, ER, or on transfer that has a tube shoved down their throat that is able to open their eyes, and especially if they start moving their extremities, yeah, you need to give them ketamine. And you may need to repeat the doses of ketamine. It's going to be written to give it every 10 minutes PRN. So you might, like the large patient we flew yesterday that was 400 pounds, I gave her 150 ketamine. By the time we got to the aircraft, gave another 150 ketamine, gave another 150 ketamine on the way there, and then when we landed, gave 150 ketamine. I gave her 600, I think that patient is a patient I've given the most ketamine to. I gave her 600 milligrams in a matter of about 45 minutes. So just know, they say it lasts 20 minutes to a half hour, but every patient metabolizes things differently, especially if they have it's metabolized in the liver, so if they have any liver issues, or if they're sick, they may metabolize a little bit differently. So just know that you may give it once, you can give it once, and you may need to repeat it, and that's when you just need to monitor your patient. And we've gotten in the habit of treating these transfers like milk runs, and we just throw the patient in the back and take these pumps that we don't even know how to change if something happens, and these medications that we're not familiar with. We throw the patient in the back and go sit in the captain's chair and type our reports. These are patients where you need to watch them and do very good patient care and treat them appropriately and watch them and see if they need to be sedated. They probably will need to be sedated, but see if they need to be re-sedated throughout the transport. Whether you're going from the VA to KU, you may sedate them at the hospital at bedside and then re-sedate them on the way to KU, or whether you're going from here to Chicago, then you might need to bring some more ketamine if it's a vent transport. So it's again just reassessing your patient and looking at your patient and watching their vitals and seeing if they're becoming more responsive, they're becoming tachycardic, they're starting to grimace a little bit, they're getting some tearing of the eyes, their eyes are open. That's a pretty good indicator that they need more ketamine.
How much are they going to put in the boxes?
2 500 milligram vials is what I've told them is the minimum.
Yeah.
Because one, you might as well just plan on having none, because one time you use it, you'll need more. So 2 is what we'll put in there. The other, so we're gonna have it for pain. We're gonna have it for continued sedation on anybody that's intubated, not just transfers, and for behavioral emergencies. This is the only drug that is effective on your PCPers. And Courtney knows just as well as I do from working at Truman that there's a lot of PCP in this city, and there's a lot of people that don't know how to handle their PCP. And most departments don't have the drugs to chemically sedate these patients. They end up getting RSI sometimes in the hospital. Ketamine is the only drug that it blows anything else out of the water. Ketamine is going to be the go-to drug for any behavioral patient, not Versed, especially in PCPers. Versed is like candy to these people. I mean, they can be shot by the police a dozen times and they'll still fight you until they bleed out. Ketamine will work very well on sedating these patients. The dosing is 2 milligrams per kilogram IM. So we know the sedation dose is 1 milligram, and we typically double it if we give it IM, so that's easy to remember. The behavioral is 2 milligrams per kilogram IM. And it might be a range. It might be 2 to 3 or 2 to 4, I don't remember, but it'll be at least 2 milligrams, so 200 for a standard adult. And again, you may have to redose it, but the good thing is it'll calm them completely down, and then as they slowly emerge out of it, you'll see it, and you may just need to redose it if you're concerned that they're going to become combative again.
Will we have to call for orders for this one?
No, you don't have to call for orders for any of it. Nope, it's completely what you feel is appropriate. If you think the patient's not sedated enough from the ICU, give it. The ICU nurse isn't going to care. She just wants the patient out of there. The receiving hospital is going to be glad that you did proper patient care and properly sedated them. They're going to be pissed. I was pissed as an ER nurse when the fire department brought in a patient who was grabbing a tube. And I used to work for this fire department. I know that there was nothing they could do, but it was just like, even the setting, they're like, well, they gave him 2 milligrams of Versed before he walked out. And it's like, they should have known that was enough. But in any case, you have drugs in your toolbox. You don't have to call for orders.
So the 9-year-old behavioral that breaks out the police car window and needs to be restrained.
Yeah, give me 2 milligrams per kilogram. He'll enjoy it. You'll enjoy it. Everybody will enjoy it. Yeah, absolutely. It's safe. It's safe. That's the thing. Ketamine, it's safe. If you give it to a patient, if I gave it to you right now, the whole vial, you would just be sedated till about 7 or 8 o'clock. Nothing bad's going to happen. You just waste your afternoon.
So when can I expect my dose?
Yeah. The night people in here are like, okay.
And just do good BLS care and watch your patient. So some off-label uses, just some trials are going on right now, some non-FDA approved uses. Clinical depression. There's been studies, there's some clinical labs out on the West Coast that are trialing this in clinical depression as well as in Europe. They're finding that patients that are deep depression, that SSRIs are not working well for the patient. And with SSRIs, it takes weeks to find the right dosing, and sometimes you got to switch drugs. They're finding that they can give an IV infusion of ketamine over 1 to 2 hours, and it completely reverses the depression for 5 to 6 months.
Wow.
And they can do this in an outpatient clinic.
Set it up.
Yeah, because it's acting on the NDMA receptors. Instead of the SSRIs, where they're just upping the serotonin and trying to make you happier, it's resetting essentially those NDMA receptors, and it's basically fixing the problem. It's fixing the problem that's causing the depression rather than just upping your serotonin. And it's like going to sleep instead of drinking a bunch of coffee to stay up. You just need to sleep and reset your mind. Like the ketamine is resetting the mind instead of just trying to up that serotonin and balance it on that end of it. That same theory is suicidal patients. Patients that are truly going to shoot themselves, jump off of a bridge, that show up, they're like, hey, they're not just doing it for attention. These patients that have true SI thoughts, they are finding that they can give a bolus or IV infusion, depends on which studies you read, of ketamine, and it's completely turning around their suicidal ideations. They give them the bolus a couple hours later, those suicidal thoughts are gone. Now they can be discharged and seen in an outpatient psych clinic or hospital. But it's life-saving for these patients that are truly suicidal, that no matter what you do, you can put them on a 40-hour hold, 72-hour hold, send them to 2 Rivers or some research site, doesn't matter. When they get out, they're going to go jump in front of a semi on I-70. This has been shown to completely change those thoughts and erase them. Chronic migraines. So outside of the U.S., they're trialing it for chronic migraines for patients that are opiate dependent. They're in the ER every day getting dilaudid. They're trying to find a non-opiate way to treat migraines. And they found that ketamine works very well. And they're sending them home with, or prescribing them with, a nasal atomizer, like a nasal mister. You squeeze it and you get a 10 to 20 milligram, whatever the dosing is, of ketamine. And it's not affecting their cognitive ability because it's in that pain management range, not the dissociation range. But it's fixing their migraines, where these patients otherwise were debilitated and stuck at home because they couldn't do anything because they had terrible migraines. And then seizures. It's starting to emerge here in the U.S. that it works very well in the acute setting, both ER and not so much in the EMS, but a lot in the ER. That it's really good for seizures, because instead of giving them, typically we give them benzos in the acute world. We give them benzos to stop the seizure, and benzos are a CNS depressant. So it stops the seizure by basically shutting the brain and CNS system down, for lack of better terms. This is because of the act on the NMDA receptors and its effect on the brain. It is stopping that rapid firing of those synapses, and it's acting like an anti-epileptic, and it's fixing the problem rather than just depressing the entire CNS system. And it stops the body movement as well. So they're finding it very effective in seizures, and that's why I've said someday we can replace everything in our NARC kit with ketamine, because it works. It works well for the 3 indications here: the sedation, continued behavioral management, continued sedation, and pain management. But it has a much wider
So
spectrum.
we're not going to use it for seizures and stuff like that right now?
Not right now. No, not right now. So a few case reviews. Motorcycle MVA, 34-year-old male patient was riding his motorcycle on the interstate when he struck a piece of shredded tractor tire. We'll say he was on I-70. The tire whipped up, wrapped around his left ankle, and partially amputated it. Did anybody see that French Olympian?
Gymnast?
Yeah, the
Yeah,
gymnast
the French
video,
gymnast, she could use ketamine. So either imagine her or imagine this guy. Or I think it was a guy anyway, and they dropped him out of the ambulance. But you find his left ankle grossly deformed, attached only by the Achilles tendon. It's just dangling there.
This is why I just do this.
He states, you ask him how much you weigh, 180 pounds. So there's his vital signs. You do all the you tourniquet, all the stuff you need to do to treat bleeding and stuff. Then then we need to treat pain. So that's important too. You give him 100 milligrams of fentanyl, and his pain's still a 10 out of 10. What's the next thing we should do? Are we going to redose the fentanyl?
No.
You could. But he didn't respond to it the first time, so is redosing going to, no. Ketamine.
Why couldn't you just start with ketamine though? Or is that not going to be
You
a
can.
protocol?
And the way the protocol is written, it is unresponsive to opiates. So you can. But in this case, I would assume he's not going to respond to my
Right.
fentanyl, so I would just
Right.
give him fentanyl and give him some ketamine.
Okay.
Because ketamine is going to potentiate the fentanyl, so you're going to get a very good effect. But ketamine will work very well by itself, but the fentanyl is just going to help, even if it doesn't help on its own. So what would the dosing of our ketamine be? He weighs 180 pounds. So how many kilos is that?
45, what, 90?
Yeah.
He weighs 81
Because we're
kilos.
doing 0.25 for trauma.
He's 81 kilos, right? I think I can do the math in my head. He's 81 kilos, so half of 81 is 40, and half of 40 is 20, so 20 ketamine. Weight in kilos and half of a half. And it may be where if the patient tells you he's 210 pounds, I may just say, okay, 220 rounds up to 100 kilos.
Yeah.
You need to be realistic, because if you do the math and you get a dose of 12.5 milligrams of ketamine,
Right.
well, look at your syringe. What do you have to do to drop 12.5 milligrams of ketamine? How much is that? It's 100 milligrams per ml, so in each 0.1 is 10, right? So it's like 1.2.
Behind.
It's 2.
I would just.
Yeah, just two.
2.
Man.
How much you get?
We had a crew member chart that, but they gave 12.5 milligrams of ketamine, and the medical director called me like, did the crew really give 12.5 milligrams? Because first of all, how did they even draw that up?
Yeah.
And they're like, well, we gave ketamine, and that's what the per the patient care guidelines says to give. I'm like, yeah, but what did you really give? And it's fine you gave 20 instead of 12.5, but I mean, it's obvious that you're bullshitting on your report. So, case number 2, called to a transfer patient from center point to KU. Patient is intubated and on the ventilator. The patient's on a propofol drip. At bedside, while transitioning the patient to your vent, you observe non-purposeful movement of the patient's upper extremities, some grimacing on his face, and high pressure alarms start sounding on your ventilator. The patient weighs 110 kilos. The nice thing about hospitals is they know the patient's weight in kilos, and it's charted all over the place on the paperwork that they send you, so you can find their weight in kilos. These are their vent settings, and that's his pressure. Pressure is fine. His heart rate's a little elevated, probably because he's anxious. End-tidal's okay. SpO2 is good. So for the purposes of this presentation, his vent settings are fine. So we know the tidal line to 400 is not causing a high pressure alarm.
Right.
What else would cause it as a high pressure alarm? A kinked tube, right? A kinked tube, obstruction of the tube. a mucus plug. All that's fine. So what's wrong with the patient? He's not properly sedated.
Yeah, he's coming out.
He might have been before you got there, and he might be for them when he's sitting in his bed, left alone, unagitated. But once we get him in our care, once we're in the back of an ambulance, and once they're moved onto a cot, whatever was working for them, fine. But we need to do what works for us, and now we have a protocol for that. So what would you do? I wouldn't even mess with the propofol drip because, again, it's not something that we have a protocol here at AMR for. So if you up their propofol and dump their pressure and they code, what protocol are you following to do that? What happens if you DC the propofol? They lose their sedation.
Yeah.
Well, you've got ketamine. That's fine. We've got something in our toolbox to sedate them for transport. So you can leave the propofol drip running. That's fine. Propofol and ketamine are compatible. Sometimes they'll give what's called ketofol drips for conscious sedation in the ER. It's a propofol ketamine mix. So you can give a ketamine bolus through the same line as propofol is running. Usually your ICU patient will have 2 lines though, if not a central line. So we want to get ketamine to this guy, right? At bedside to make our jobs easier before we get down all the way to the ambulance. And you may remember you may have to redose it maybe once or twice. Patient weighs 110 kilos. We've already got the weight in kilos. What's our sedation dose? 1 to 2 per kilo. So how much should we give him? 110?
Yeah.
220?
Yeah.
I'd probably give him 200.
I was thinking 150.
Or 150.
Yeah.
Yeah. So you've got a range, but just know it's 1 to 2. So
If it doesn't work.
you give some more. Yep, absolutely. Nobody's going to QA your PCR and say, well, you only gave 100 and 100. Yeah. May say, you could have given more because you had a wide range, but as long as you're understanding when the patient needs it and understand the dosing and the 3 different indications here at AMR. I've seen the protocol. It's pretty straightforward. It's pretty easy to follow. It's pain, sedation, or crazy guy. You have an intubated 56-year-old male in cardiac arrest. You now have ROSC. The patient is attempting to moan. He has eye-opening and painful stimuli. You estimate the patient's weight to be at 200 pounds. So, we're not going to want to extubate this guy. He's trying to, he's waiting, he's got ROSC. He's one of your cardiac arrest saves that might walk out of the ER. So you've tubed him. Patient should never be alert or awake and be intubated. So we need to sedate him. He weighs 200 pounds. What's that in kilos? 90. 90 divided by, pounds divided by 2 minus a tenth. So 100 minus a tenth is 90. So 90. So you give him 90 to 180, right? And then these are his vitals. Again,
It's not going to drop his blood.
No, I mean, if you're going to see anything, it's going to be a slight increase. His end tidal's high because he's been in respiratory arrest, cardiac arrest, and now he's got all the CO2 buildup. Somebody asked about going directly to ketamine instead of opiates. Your trauma patient that's hypotensive. It's got, hit by a semi, it's got crushed pelvis or bilateral femurs. Right, so that may be a case where you want to go directly to ketamine and just document, patient given ketamine because of pain and because of blood pressure.
Worked on all your gunshot victims.
That's it.
Cool.
Any questions? I don't want anybody to feel uncomfortable giving ketamine or feel that they're going to harm the patient or it's just a new drug, so like anything, it takes a while to until other people give it and see how they what their interactions with it. But I get it a lot. The thought was, if you have a bad patient, like that side of that, I get that.
Get an IV right here, but then on the way, they're blow up when this whole pops up out of the bed.